In this podcast episode, I interviewed the lecturer for my Women's and Gender Studies class, Joanne Motiño Bailey. Joanne is also the director of nurse midwives at Michigan Medicine. In this episode, we will discuss birth disparities and how they impact women locally and globally. I guess to start out, just tell me a little bit about yourself, your job, you, everything.
Let's see. My name is Joanne Motiño Bailey. I'm the director of the nurse midwives at the University of Michigan Health System. I'm also a lecturer in the Women's and Gender Studies department. And my job as director of nurse midwives is sort of threefold. It's clinical practice. So I work as a midwife in a couple of different roles, and I supervise and support another 35 midwives that are here at the University of Michigan. And I am involved in a small amount of research and just mentorship around, in between LSNA and the medical system here. And a large portion, I guess, of my administrative or my leadership roles is around trying to support and improve our care that we're providing to all families that receive care for pregnancy, labor, and birth here at the University of Michigan.
Okay, awesome. What was your educational path to become a nurse midwife? So like from when you graduated high school to now, what was
So a little windy. So I'm not the person that, knew exactly what I was doing every step of the way. So I did all of my degrees at the University of Michigan, which wasn't really intentional, but it was very convenient for me and my family. I have an undergraduate degree in Japanese language and literature from a million years ago, and I did my pre-med studies then. I was then a healthcare volunteer in Honduras in Central America, working mostly with women and children with AIDS or HIV and AIDS. And that was back in the day where getting an HIV diagnosis was essentially a death sentence. So very different world today, which is super wonderful. And when I was working there, I had the experience of working with all sorts of different healthcare professions. And so that was the first time that I'd worked with professional midwives, because my interpretation of midwifery was kind of unlicensed, uneven training, et cetera, of home birth, as opposed to advocating for all those midwifery practices in established healthcare network and system. And so when I came back to the United States, I moved back to Ann Arbor again because it was a familiar location, and started the pathway towards midwifery. So I did a second career in nursing, and which was like an accelerated bachelor's in nursing program for people that already had a bachelor's degree. And then I did a master's degree in nurse midwifery and also as a family nurse practitioner. And then I did a PhD in women's health in the School of Nursing. So that's all.
Okay, long path.
Yeah, took a while. I had like 2 kids in the middle there, and worked full-time in clinical research for a while before I became a midwife. So lots of things.
Okay, yeah. What's your favorite part right now about being a nurse midwife?
Oh, so my favorite, well, I have a couple of favorite parts. Like one, I love being at birth, right? Being with people during this really intense, painful, usually very joyous, but sometimes extremely tragic, but a very intense moment in their lives, and being present and witnessing that and supporting people is just a wonderful, wonderful experience. And then the other, kind of companion part to that is caring for people across a long span of time. So not so during their entire pregnancies, even if I'm not there during the birth, seeing them while, when they have their newborn, and then seeing them postpartum, having them come back to me for birth control or come back to me for a subsequent pregnancy. So kind of that relationship in that arc. I feel like we all hunger to be known and cared for, not just a number, but really cared for. And so I just love providing that care.
In your day-to-day work, do you only see women who are pregnant or trying to get pregnant or giving birth, or do you also see
so I do a scope, like kind of like all, like the whole reproductive scope. I don't I rarely see anyone who has gone through menopause, but rarely. The majority of the care I provide is like pregnancy related. So probably like 80% pregnancy related. And then the other part is like annual exams and birth control or putting in IUDs and things like that. So a little bit of enough so that everything's a little bit different, which is how I like to live. I would be bored if I had to do the same thing every day. So in my current life, I get to do different things every day.
Yeah, like you had said before I took Women's and Gender Studies 220 this semester, so I knew a little bit about you. But before that, I kind of assumed that a midwife was, like you said, like unlicensed kind of. I didn't know that they could do such a wide scope of things.
Yeah. So it's really wonderful. There's so much that we know. I mean, that teamwork is really how we improve care overall. And when you look at hospitals that have midwives that practice there, they have lower C-section rates. And even if you don't see a midwife, but you go to a hospital where they have midwives, you're less likely to have a cesarean. So there's benefits just for having us around and our philosophy of care, even if it's not directly impacting an individual.
Could you see yourself being any other type of nurse, or is this, do you think?
Yeah, well, actually, my plan has always been, so, like I told you, when I was really young, I worked mostly with people with AIDS, and I were with a lot of people who were dying, right? And so there's a lot of similarities between birth and death as far as these huge, obviously, challenging times for families. And one is very joyous often, but can sometimes be really tragic. But so anyway, so I find a lot of similarities between birth and death. And so I often think when I'm done doing birth that I will do more end of life care, like palliative care and hospice care, because having good, peaceful deaths is something we do a terrible job at in this country as well.
So do you have a plan for when you might switch to that, or are you just going to?
No, my staff, I don't know, maybe in retirement I would do that. So maybe that would be another, 10 or 15 years from now. It's kind of hard I never thought I would be in the role I'm doing for as long as I'm doing it, but it's still fun and exciting, and I get to do different things and learn new things. And so I keep doing it. So we'll see. And for better or for worse, I've been at deaths and done hospice support just for friends and family. So it may not ever be like an actual career, but maybe more of a volunteering support or something. We'll see.
That's really interesting, especially your comparison between how similar life and death, or birth and death, are.
Yeah. So, and like from a physical perspective, I mean, like labor is like a very physical, you can say it's like magical and bringing new life into the world and stuff, but it's like very physical. You puke, you have diarrhea, you're like working so hard. There's a lot of like just physical work and pain and challenge to get through that, and dying process is in some ways very similar. There's a lot of like just physical body stuff, even in the midst of this like very cosmic experience, really, of leaving the body.
Okay, now I'm gonna kind of switch from asking about your career to like health disparities. I know we talked about it a lot in 220, and then also I wrote a literature review on it this semester.
Okay.
It focused in a specific area,
Okay.
but I wanted to ask you a few questions about that.
Sure.
So when in your life or in your career did you first become aware of health disparities among women? Was it a personal experience you had, or was it more just at school? Or
Oh, it's such an interesting question. Wow, when did I become aware of it? Well, certainly, I think, I said I had worked in Honduras, and I worked mostly with people who were quite poor, and just the tremendous disparity, so that was a time where in the United States, people had access to early antiretrovirals and things. And so being in Honduras and realizing that people, this is a death sentence here, but it's a death sentence because there's not the funds or the access to these expensive medications that are available in rich countries, so, and we see that replicated like with COVID vaccinations today or treatment for COVID, right? So I really came in many ways at the question around health disparities from thinking about the relationship between poverty and privilege of, why is it that we have these incredible disparities and these credible, isn't being able to live a safe and healthy and long life something that everybody should have access to? And so, I would say that my first entree really around the health issues were around poverty, so like economic disparities. And then once again, when I was in Honduras, I worked mostly with women and children, some men, but mostly women. And of course, there were like so many different layers of dealing with people with HIV and AIDS, so that mothers were women with HIV and AIDS almost always got it from a partner. And so thinking about power dynamics, which led to that, and the complexity around their children and the tragedy around watching their children die or watching their children be orphaned. And so thinking about how women bear the brunt of suffering in a completely different way, not that men don't suffer, right? But the burdens are very, very different. And so I would say it was that real visceral lived experience that framed a lot of my understanding of women's disparities and how that kind of those intersections come together. Coming here to the United States, or when I returned here, I worked actually in cervical cancer prevention research for some years, and very similar situations that we see if we talk about breast cancer or others, where marginalized women are just much more likely to be diagnosed with more advanced cervical cancers or have issues around that. And so it was kind of early in my exploration. I mean, I remember taking a class as a graduate student in intersectionality, and like it was language that we weren't really using yet, and yet to me it was like so powerful, giving these examples of we can't just look at these, one aspect of a person's identity, but who they are and how the world sees them, and how that larger social context, how that gets inside the body and impacts us differently, or differently depending on our social situation and identity.
When in your personal practice as a nurse midwife, have you seen these disparities come to life, like seen it happen to women that you're caring for?
Well, I certainly see it on a daily basis with people's access to resources, right? Can you come to the appointment? Do you have transportation to get the appointment? If you, like right now with COVID, you're not supposed to come with your kids. Well, I've had people who are like, I don't have anyone to watch my kids, so I can't come to an appointment. And I'm like, you know what? You can pull up to the front and I will come down with my stuff and I'll see you in the car, right? If they're not going to let you in, so just all these ways in which the system is not built for people who don't have a support structure or have the resources in order to, have somebody else watch their kids.
Yeah.
For example, I mean, and I see that. So it's like transportation. What is, when they call, how long do they have to wait? And so they're using up minutes on their phone, just all the barriers that poverty plays, and then how people's social situation impacts over that, and then just increases those barriers. I mean, I think the other part of what we're just seeing so much now that we've been really explicit of, now that we talk really explicitly of like the increased maternal mortality rate for Black women, then there's the question of, well, what do you do with that information? If you're a Black woman, are you just terrified you're going to die the whole time? And that may be really important message to get out there so that we start working towards changes, but it's actually just very distressing that that's the only narrative that people have, because it feels like something that they just don't have control over. And so watching how our disparities, even as we're trying to address the disparities by making them so much more clear and stating them aloud, we're also not fixing things, but creating a lot of fear at the same time too.
Yeah, I'm gonna ask you about a little more in depth about that a little later, because that's what I focused on in my literature review.
Mhm.
I guess my next question is, what do you think is the most pervasive disparity in women's healthcare right now? Was it one of the ones that you said? I don't mean just in your practice that you see, but like in the world or in the country.
Most pervasive. I mean, certainly the thing that we see the most, is getting a lot of press right now is Black women dying at a higher rate than white women, and how we are doing a very poor job of moving the needle around that. So I would say that that is, and what leads up to a death is a whole bunch of other complications or near misses or risky things, right? So when you talk about an actual death, that's like the small number. But if you talk about like a serious complication, like that's this much huger number. And then if you talk about just increased risk, that's this huge number. So you see, if you back up a couple of layers, it's just the burden of that increased risk is just tremendous on individuals.
So I said this a couple of times, but so I wrote my systematic literature review focusing on the impacts that race and socioeconomic status have on birth outcomes. So I focused on rates of preterm birth and low birth weight. And I was interested to see that a big part of why Black women experience worse birth outcomes and higher rates of mortality have to do with the stress that racism causes them on a daily basis. Do you have any insight on this?
Well, I think this goes to how does the world in which we live and move about, how does that get inside the body, right? And one of the big contributors to increased morbidity or like sickness or mortality is cardiovascular changes. And we absolutely know that stress and response to stress is very much connected to our cardiovascular system and a wear and tear on our cardiovascular system. So so that makes a lot of sense that those things are connected. Same thing that, we still don't understand pathways of preterm birth, for example, very much, but certainly when you compare cortisol or like stress hormones for people who have preterm birth versus not, there's a connection there as well. And obviously it's not every person that this happens to, and yet it's just a preponderance, or the scales tip towards that, and that's just a incredibly unjust burden for some people to have compared to others. And I think you're doing a terrible job in this country of thinking about how do you address this. In fact, what we're hearing as a response kind of politically is sort of like all the critical race theory in schools, et cetera. Well, let's just pretend like enslaved people were just workers, and let's just pretend like these things didn't happen, and yet erasing that or not calling out is very traumatizing as well, like saying that this didn't happen.
Do you can you think of any solutions or what healthcare providers can do to minimize this, or does it have to be on a bigger scale, do you think, the changes?
Well, I mean, there's so many different layers in which I think there's a lot that we can do. I think of it from education, for example, like one of the most important things is we need more representation, more people of color working in the healthcare world. And what we have to do is we have to really work hard to increase those numbers beyond what we're doing right now. And that involves, recruiting people and really fostering people all along. In the healthcare professions. We need to have better community access, right? Really reduce barriers. Like when you say that people can't bring their children to appointments, understanding it was for pandemic and all of that. But when you say they can't bring them, that creates an additional barrier that makes it harder for someone to seek services. And so thinking about those social barriers and coming up with new and creative ways to take care to people as opposed to expecting them all to come to us. That is a thing. And also just an awareness, right? I mean, I think you ask any African-American person, they have known all along that all of this intrinsic racism and bias is built into the system. And it's only been in the last few years where it's been acknowledged as like a real thing by other people. And we still have an entire political party that's trying to pretend like it doesn't exist. So, all of that is harmful too. Until you admit something's there, it's hard to create changes.
Mm-hmm. Now, I know that race and socioeconomic status are intertwined, but I'm going to ask you this question kind of separately. But how have you, or what do you believe is the biggest health disparity facing women of low socioeconomic status? So I guess there's even worse disparities for Black women of low socioeconomic status, but just in general.
So I think everything is harder if you're poor, right? Your transportation, you're supposed to come and get, you have some kind of like, there's something where we're worried about the baby's growth and you need more testing. Well, you have to come, like here at U of M, you have to come to the hospital, twice a week. And well, you know what, you have to pay $3 to park every time you come. And that seems like not much of a barrier for some people, but is it a barrier? The $3 plus the gas to come here ends up being a barrier. So then you're less likely to do the monitoring. And so then there might be neglect. So it really ends up being access barriers that are there. And I think that those access barriers get replicated over and over again. Like right now, institutionally here, we have all of the stuff that's on like a portal, like a patient portal, where you can see all of your records and you can basically text with people with your questions. But that means that you have like an iPhone that you can do it, that you have a data plan, that you can do all of those things. So, we're baking into the system access problems. And, even as we're making, affluent people who have their phones and all of that, making access easier and letting them do all of that, we've made it more difficult for other people.
I definitely agree. I've used the patient portal system and it's awesome, but that's because I have access to the internet.
So, like my Spanish speaking patients, like, actually I have a couple of Spanish speaking patients now that, will send me messages in Spanish, and it like freaks out like my staff because they're like, well, we can't read that. And I'm like, I don't care, I can read it, so it's not a big deal, just forward it to me, no issues there. But the system makes it, the system has those barriers. I'm trying to think what else I want to say about that. I just want to say one really brief thing about race and socioeconomic status and how they're intertwined. And in the end, what we need to do to fix our racism issues is we have to fix the socioeconomic status issues. The rest, or much of the rest, will just continue to autocorrect or improve as we're doing things, but you have to have more access to resources.
Okay. Yeah. And my last question was going to be, tell me a little bit more about now how race and socioeconomic status are intertwined.
Okay. Well, what I would say, so this is kind of radical and it's not fully my ideas, but I have come to understand this more. So for example, when we look at the gay rights movement, so we're still really struggling with trans rights movements. So it's not like we've come off where we want to end, but we've made huge strides, like for example, legalizing gay marriage. And if you think about that, one of the big issues is you could change kind of social beliefs around that, but legalizing gay marriage didn't have a financial component to it. It's not like there was money that people had to invest in it. If you start to really acknowledge the roots of racism, you have to look at how financially we have absolutely robbed people of access to resources, including their bodily autonomy. If you think about period of enslavement, and then all the being barred from land ownership afterwards, that after the end of slavery, right? So we have robbed people of those financial benefits, and in order to create shifts around that, there is a financial reckoning that has to happen, and the powers that be which include us, are unwilling to address that reckoning.
Okay. That is my last question for you. So I am all done. I really appreciate you agreeing to meet with me. This was getting to talk to you more. I want to thank Joanne again for joining me on today's episode. The information that she shared was very informative and opened my eyes to new issues about women's health and birth disparities that I was unaware of. I hope we can all take this as a message that there is still so much work to be done to ensure that birth outcomes are equal for everyone, no matter their race or socioeconomic status. Thanks for listening.